It's way more attractive than the blue man. So I'm going to bring the slides up. So can you?
Yeah, I can see.
Page. Okay. So again, when I bring the slide deck up, what I'm having is I can only see the slide deck. I can't see the window for the Hangout thing, but it's okay because I only need to really see the slide deck.
Yeah.
Okay, so on page 1, the first one didn't change, but I did add this. So the 6 functions of the kidney are
to filter blood.
Yep, blood filtration is the first one.
The acid-base balance.
Yep, pH balance or acid-base balance.
To make erythropoietin.
Yep, which is blood producing, right? Red blood cell producing.
Yes.
And that would also help control blood pressure as well.
It has to do with renin and vitamin D.
Yeah, so there's blood pressure and then vitamin B. So the 6 based on what the notes say: filter blood, blood pressure, acid-base balance, make erythropoietin, make him release renin, which is the first step in raising blood pressure, and then activate vitamin D as a mineral, kind of as an enzyme.
Yeah.
Okay. So there are 2 lab tests. There are 2 general lab tests that that we do on the kidneys. And so there's the 2 main categories and the 3 tests below them and the 2 tests below them respectively. Do you remember what the 2 types were?
Well, there's a blood test and a urine.
Yep. And then what are the 3 under blood test?
Bun.
Yep. Blood, urea, nitrogen. Yep.
What was it? Creatinine?
Creatinine, yeah.
And then I can't really remember the other one.
And the last one was, I want to say GFR. Glomerular filtration rate.
Yeah. Okay.
So that's the 3 blood tests. So what's the other test?
The urinalysis.
So yeah, so it's urine test is the general category. Then urinalysis is the first test. And then what's the other one? So remember, there's one test that we're going to see in both categories. There's one test that's in both.
Oh, was it the creatinine? Yeah,
creatinine presence would be in blood, and the creatinine clearance rate, which we're going to also see with GFR. Does that make sense? We should see a relationship between GFR and creatinine clearance because that's one of the ways that we test GFR. We look at a baseline of creatinine clearance, and we look at creatinine clearance over that 24-hour period, and that's going to give us an indicator of what the GFR is.
Okay.
And that's a little bit of a review from physiology. When you went through your physiology lecture, they probably talked a lot more about creatinine clearance testing in relationship to how that indicates GFR.
Yeah.
So that's the only reason I talked about it. So there's glomerular filtration rate, which is a blood test, and then there's creatinine, and you have to have both of those together to show real kidney function.
Okay.
Okay. So good, you got those. So that I added that in. That was one of the add-ons to page 1, or excuse me, page 2. Okay. Under urinalysis, remember, under urinalysis, we're specifically testing specific gravity.
Yes.
Okay. And then I'm going to add. I didn't add this today, but the abnormal substances that we're looking for in the urine, what are they? Things that we would see in the urine that would show abnormalities or damage.
Protein.
Yep, we're going to see protein. That's one of them. There's 2 blood products that we're looking for that would be present in abnormal urine. So think about whole blood.
Yeah.
And think about 3 components to whole blood. What are the 2 that we're going to see in damaged kidney urine?
Red blood cells.
Yep, red blood cells is one.
White blood cells.
White blood cells, correct. Okay, and the presence of each of those is going to tell us certain things, correct?
Yeah.
Okay, so what do you think the other 2 are? So what's the
like ketones or like
so ketones are a product of what disease? When we see ketones in the blood, who do we traditionally see that with?
Diabetes. Yeah,
diabetic. So glucose present in the blood as well as ketones are a really good indicator of diabetes.
Okay.
Okay, so glucose in the blood, and the last one is so when we get kidney stones,
yeah,
in the blood in the urine, Those are called casts, or crystallized mineral structures.
Okay.
So those are actually called casts as a general rule. Okay. So that's just a little quick review on a urinalysis test and what specifically that test should tell us. Specific gravity, and then those abnormal substances are either present or they're not present. And as those develop and show presence, that's going to kind of give us an indication of what kind of urine disease of what kind of kidney disease we're seeing, right? If we see red blood cells only and no other products in the urine, what kind of damage are we getting, and what kind of disease does that show?
With red blood cells?
If only red blood cells would be present. If we have normal urine, normal specific gravity, all things being equal, and the kidneys functioning normally, but there's red blood cells present.
Wouldn't that be like, that could be like inflammation or something?
Well, kidney stones, because remember how they're the balls of kittens with their claws out? So they're basically cutting and damaging the cell walls of the urethra and as they go out. And that's causing red blood cells to be released because there's physically been a cut. And so it's allowing red blood cells to leak in and the urine to get out. But no other things are present. There's no white blood cells. There's no protein. There's no glucose. Any larger structures to damage the glomerulus. Those casts develop in the renal pelvis, and they roll down the ureter and damage the ureters at a lower level.
Okay.
So I think if we continue to have damage from a kidney stone, we may start to see some white blood cells, but that would definitely be a later sign, and we start to see other additional problems with that.
Because
that would be
an infection or something.
Yeah, we get an infection, and we may get that ATN, which is that acute tubular necrosis. As that kidney stone gets lodged and it backs up the urine, the ureter's been cut because those stones have been going down. It gets lodged, so now you've got an inflamed cut. It's starting to back up urine, and so then we probably start to see ATN. That makes sense. Yeah. But then the diagnosis wouldn't be kidney stones; it'd be ATN, and we would merely treat the kidney stone to remove it, and then we'd have to go on and then treat ATN.
Yeah.
So that's it. Good. See that when my notes are better, my slides are better, I think we have a better discussion.
I do too.
So I apologize that they were a little bit sketched, but I did get about 25 minutes to an hour to work on these, and so I cleaned them up.
Yeah, they look good.
So under blood tests, if you're with me on the slide deck, the first two are blood urea nitrogen or BUN. Measure BUN in blood can indicate kidney damage, but is affected by hydration as well. Okay, so you need your BUN, and you need a creatinine levels must also be elevated to show true kidney damage.
Okay.
So if your BUN is elevated, but you don't have any creatinine with it, then there's something going on. There could be the potential for kidney damage, but it may be early onset. Does that make sense?
Yeah.
But if we see an increase in BUN and an increase in creatinine, then we're definitely starting to see elements that are combining to show true kidney damage.
Okay.
Okay, so normal range for a BUN test would be 20, less than 20, with the pneumatic. 10 buns equals 20 butt cheeks, or the other one, which was 10 plus 20. And then urea is a byproduct of protein metabolism in the liver. Okay, so that's where urea is coming from, is protein metabolism in the liver.
Okay.
And ammonia, remember, the creation of BUN is the most important pathway for eliminating nitrogen from the body. Yeah. Okay. So or elevated nitrogen levels. Okay, because in everything with the body, there's a normal zone that's appropriate. Okay, so now we're to page 2. So specific gravity. So what's specific gravity weigh? What?
10 plus 10 plus 10 plus, or 10 plus 10 plus 10, and then 30.
Yeah, equals 30, right? So 1.010 to 1.0320 is the normal range for specific gravity. And remember, the definition of specific gravity is a substance in relationship to its density to water. The more dense it is, it will sink. The less dense it is, it will float. So urine sinks to the bottom of water, where gasoline floats on water. So gasoline would have a lower specific gravity. Water would be 1, and then obviously we know urine is 1.1010 to 1.030. And so it would sink in water.
Okay.
Okay, and so it says here, the last note under specific gravity, this can also be a measure of hydration level. So if someone is dehydrated, what is going to happen to their normal range? If they're in a dehydrated condition, what's their normal range going to look like?
Isn't it going to be, would it be higher?
Yeah, remember this one's kind of like pH. It's counterintuitive because is blood that's less liquid, has more red blood cells and more plasma proteins concentrated, is that going to be heavier in water or is it going to be lighter in water?
Lighter.
No, if it's more concentrated.
Oh, if it's more concentrated.
Yes, it's going to be heavier by weight and it's going to want to sink. So we'd see that at the 1.030 to 1.035, right?
Yeah.
That would be you're dehydrated. If you're fully hydrated or even overhydrated, you'd see a level that's going which direction?
It'd be low.
Yeah. So if you had a patient that you had given a 500 milliliter bolus of like normal saline and you looked at their bun or their specific gravity after you did that and their specific gravity was at 0.95, would that be bad?
Yeah.
Yeah, that would be a graphic or a data driven indicator of fluid overload. They would be fluid overload at that point, and that would be another reason to stop giving them fluids.
Yeah. Okay.
Cool. Okay, so that's specific gravity. Okay, so in class, page 2, key terms. Okay, in the very middle of that page, there's some key terms. Remember what they were?
It's the azotemia.
Yeah, azotemia. And what? Go ahead and read it out from the book. If you're looking at the notes, just read it out.
Yeah. Increased bun and creatine in the blood without systemic signs and symptoms.
Okay, so that's one thing, right? Look at the next one.
Uremia. Increased bun and creatine with multiple system organ failures.
Okay, so between those two terms, they're closely related, aren't they?
Yeah.
So which one's worse? Which one's a more serious condition?
The azotemia.
Yeah, uremia is the more serious one because it's increased bun and creatine with multiple system failures. Where azotemia is increased bun and creatine, but we're not seeing a systemic response yet. It means your body's compensating those elevated levels, and it means as a nurse, we have some time to deal with that, to give them fluids and to try to get that filtration level to more normal rate. If they're already in uremia, we're already starting to see cardiac and pulmonary tissues potentially. They could already be having neurological issues. And that's a more serious situation because now we've got them not responding and the body's no longer compensating.
Okay. For some reason, I thought it was like symptoms or whatever that like that which one was worse because it was like internal, so you couldn't see anything. And so then, yeah.
Yeah. Okay. Yeah. The difference is, again, just like I said, some of this stuff is really subtle. You know what I'm saying? It's very, very subtle. Mm-hmm. Be paying really, really good attention to like without symptomology, with multiple system failures, right? That's going to clearly be the more serious condition. Okay, polyuria is an increase in urine output, and it could be due to a pathological condition such as diabetes, but you also just maybe you need to get a drink of water.
Okay.
Right? So you may not have any kidney damage if you have polyuria, but again, polyuria, it means you're urinating too much. Maybe you just drank a lot of fluids that day and you're urinating a little bit more than what you should. And that's just an indicator, hey, slow down. You don't need to drink quite so much.
Yeah.
Oliguria. What's oliguria?
That's a decrease.
Yeah. In urine output. That's a decrease in urine output. And again, that may not be a pathologic condition. It just means that you need to drink some fluids. Like that's the opposite of polyuria. You need to drink some fluids. It may not be pathologic at that point. But if you get into anuria, that means you have no urine production at all and your kidneys have definitely failed. And now you're dealing with a more serious issue.
Yeah.
Cool. Okay. Sorry, you go finish your thought. I'm sorry.
Oh, I was just going to say because you make no urine production.
Yeah,
So that's bad.
a little like reduced or a tiny bit as opposed to none.
Yeah.
So, okay, cool. Okay, so in page 2, I haven't really talked about renin and or excuse me, RAS. That's in page 2. That's the next thing I'm going to talk about. So what I'm probably going to do is build an organ flow chart like I did on the board for class for the slides.
Yeah.
Sounds like you're going to do the same thing, but with little cutouts so we can, put them up or play with.
Visualize it.
Yeah. So I think if we hit both, we'll get both learning styles, and it'll be helpful for both of us.
Okay.
Okay. Cool. Okay. So on
next.
Sorry, page number 3.
Okay.
So this one here I got to fix up because basically it should say ADH, and then it should have vasopressin blank. It should be one blank, and we could go through those different things. But let's just go through them really quickly. So it's secreted by the posterior pituitary gland. Okay, what's number 2?
Released because of osmolality.
Yeah, so and in the notes it talks about an increase in blood concentration. So if you're losing too much fluid and your blood's getting too concentrated or too viscous, then that's when your kidneys and your brain say, hey, wait a minute, this isn't what we need. And they start to secrete these hormones to get that to say, hey, hold on to the water, man, don't let that go. Okay, 3 says relates body water by signaling kidneys to retain sodium and H2O. And we talked about that last night. So you explain to me what number 3 means.
Okay, so with the sodium, if it's going to regulates water in the body by signaling the kidney to retain water and sodium. So because sodium is a big molecule, water's going to follow it. So it's going to want to keep the sodium so the water will stay in there and retain.
That's the body's process of retaining water. It just holds onto the sodium, and where the sodium is, the water stays. But what happens when that what happens to blood pressure when that happens?
Wouldn't it stay the same, or would it increase?
It actually goes up because the volume of blood has gone up.
Okay.
The total volume of blood's gone up because you're retaining sodium and water. It's keeping the volume of blood up, and so that's going to keep the blood pressure up.
Okay.
And remember, think about the RAS system and what the RAS system actually does to elevate blood pressure. That's exactly what the RAS system is doing. The aldosterone and angiotensin 2 are specifically telling the body to hold on to sodium to hold the water in the blood.
Yeah.
So if that's another way of saying, so ADH and the RAS system both work in conjunction to raise blood pressure.
Okay.
The way that they do that is by holding on to fluid. Okay, so number 4, the secretion of ADH is caused by low blood volume, low sodium volume, and high osmolarity of blood fluid. So i.e. dehydration means with low ADH will cause fluid retention to relieve dehydration.
Mm-hmm.
Okay, so there's that one. So any questions on that?
Nope.
And the street drug name for ADH is what?
Vasopressin.
Vasopressin, yep. So so if you ever hear me say, what's the street drug name for ADH? You know it's vasopressin. If I ever say, what's the scientific doctor way of saying vasopressin?
Antidiuretic hormone.
Antidiuretic hormone or ADH. Okay, awesome. Okay, so here's some new stuff with the note.
Okay.
So natriuretic hormones, there's ANP and BNP. Both lower blood pressure, but how do they work? But how do they do that?
Okay.
Let's start from where those ANP and BNP come from. Where do they come from?
So ANP comes from the heart.
They both come from the heart. They both come from the heart.
Yeah. Okay. Both come from the heart. But the ANP comes from the atria.
Yeah, that one's easy to remember because atria and A are the same. Okay, but the B one's a little bit sketchy. So what's going on with B? So
BNP is produced by the heart ventricles.
Yes, and the reason that it's BNP is because 120 million years ago, that particular chemical was.
We know this. Yeah.
Okay, so tell me the history of BNP and why it's called that.
That just all cut out.
Sorry, so BNP. So can you tell me the history behind why BNP is called BNP and not VNP?
Well, it has to do with the ventricles, not the brain.
Yeah, well, that's where it's coming from, is the ventricles. But remember the history of BNP. Originally, when this was detected, it was detected in what system? Where did originally scientists detect this?
Was it the nervous system?
Yeah, they detected it in the nervous system up in the cranium, right? And so science said, hey, it must be being secreted up here somewhere. They couldn't necessarily detect where it was being secreted, so they called it BNP, or brain like neutralizing hormone, or whatever, right? Yeah. Brain neural protein or something, right? Whatever. Look what those acronyms mean. And then it was later on they followed the stream of BNP and found, hey, wait a minute, it's being secreted by the ventricles.
Okay.
And by that point, it been BNP for like 180 years, and then they just didn't change it, right? They updated their research to show the correct location of where it was secreted, but they just didn't update. They still call it BNP out of tradition.
Okay.
And maybe, and seriously, maybe in our lifetime or in our careers, we might actually see it change eventually to VNP. It might actually change to where it actually comes from, as opposed to just tradition.
Okay.
You know, as we've gone through anatomy and physiology in like the last year, haven't you heard your professors say, hey, we used to call these mitral valves, and now we're going to the more common or more medically correct term of atrioventricular valves?
Yeah.
Because they're trying to get more streamlined and more in line with what would be normal, like what is easier to remember and what makes sense, as opposed to it was tradition to call it a mitral valve.
Yep.
Okay,
which
awesome.
I like the AV valve better.
Yeah, it's a little bit easier to remember. I learned anatomy years ago the first time, and so I know them as tricuspid and bicuspid and mitral valves from that. But clearly, I can also remember AV valve. You know what I mean? It's not that big a deal.
Yeah.
Okay, so what do we know? What do we know about ANP? Where does it come from? We know that, but what does it actually do?
So it blocks the aldosterone secretion.
Yep, it blocks aldosterone secretion, and it does what else?
And inhibits renin.
Yep, it inhibits renin. And BNP?
So it's produced by the heart ventricles.
And how is it produced by the heart ventricles? What's the catalyst that causes it to be produced? When
the ventricles or heart is stretched.
Yeah, when the ventricle muscles stretch beyond its limit, like say in high blood pressure, then it's being released and saying, "Hey, wait a minute, let's lower the blood pressure."
Yeah.
I'm taking too much stress being stretched out. And then I just put the important note. What does the important note say?
Let me scroll down.
Well, no, it's on the slide. It's the blue box I added in there.
How do you say that? Natrium?
Yep.
Latin for sodium. These hormones allow sodium to be excreted out of the body.
So if natrium is causing the sodium to be excreted in urine out of the body, what did we talk about before? If sodium is being pulled out of the body, what's going with it?
Water.
Water's going with it, and so our total blood volume is going to be lower, and it's going to do what to blood pressure?
Decrease.
It's going to cause it to decrease. Perfect. Good. And then there's obviously the little notes, right?
Yep.
So we got all that. Okay. The one thing that we didn't get for BNP is BNP detecting can also be used to detect if in a sample we detect BNP, then it can also be used to detect heart failure, that your heart's in a condition of heart failure.
Okay.
And then I put that little note, ouch, stop stretching me out. Producing ventricles are stretched too far. And then I just put a little funny note to help you remember. And then I also put the notes under ANP. If you look at the notes under ANP, so it blocks aldosterone. And the way that it blocks it is aldosterone is produced where?
The adrenal medulla.
Adrenal medulla, right? And then renin is produced where?
In the kidney.
So what we're seeing is ANP is really acting upon which organ?
The kidney and the kidney.
Because the adrenal medulla sits right on top of the kidney, so that ANP is basically traveling from the heart down to the kidney, and it's responding to all the structures there.
Yeah. Okay.
Okay, page 4. I didn't get a chance to update this one at all, so we can go over it again, or we can just move on. So pyelonephritis.
Yeah. Okay.
Bacterial infection, right?
Yeah.
And how does it normally work? How does pyelonephritis normally work?
So, okay.
I mean, it can come through the blood system, the bloodstream, right to the kidneys.
Yeah.
But how does it normally get to the kidneys?
Isn't it just through the urethra?
Yeah. So like you're a lady and you get a UTI, right?
Yeah.
And that festers and doesn't relieve. It doesn't get relieved, so it starts to move up your urinary tract from the vaginal orifice up to your bladder, up from your bladder through your ureters up to the kidneys, and that's when you get. And then it moves into those nephritic tissues and causes that inflammation and damage to move all the way up into those structures.
Okay.
So basically, it's an ascending infection that moves up through the urinary tract.
Okay.
Okay, and that's why females obviously get it a little bit more consistently than men, because your urinary, your GI, and your sexual tracts have very close association to each other, and so there's a cross contamination and opportunistic infections to move fairly easily. Sorry, you're a girl, and just anatomically, your structures are close together. All still friends. Okay, and then urine backflow is most likely the most common cause. So when you get a blockage in your urethra or your ureters, then you're going to start to see pyelonephritis.
Yeah.
Okay, page 5. So this one I've updated a little bit. So glomerular disorders, there are 2 types. Do you remember what they're called? It's actually really easy what they're called. When you hear them, or if you don't remember them, you'll be like, "Why? How the heck did I not remember that?"
Okay, I don't remember. Let me look.
Primary and secondary.
Oh, well, that's easy.
There it is. I just knew. I knew as soon as you heard that, you'd be like, "Damn!" So primary glomerular disorders. What was the primary one?
It is the untreated, right?
Yeah, untreated group A strep, right?
Yeah.
So then, what would be the secondary type?
Caused by other.
Yeah, other. It's caused by other, but the other is like drugs or poisons that are introduced to the system that cause glomerular damage.
Okay.
Okay. So type 1, primary, we talked about, was caused by
Streptococcus.
group A strep, and then number 2 is caused by
drugs.
Other stuff, and the other stuff are drugs, systemic diseases such as diabetes and lupus, vascular disorders, and then viral infections.
Okay.
Okay, so that's a good review for you. I knew as soon as you heard primary and secondary, I knew that stuff would come back. We actually study together fairly regularly now, so I can almost tell by the tone of your voice what's going to spark your memory. That's weird to say that. I'm getting to where I know you pretty well.
Yeah.
So I know sometimes when I just say one thing, you're like, oh, damn it. Okay, page 6, I didn't get. Page 7, I got some stuff for page 7. So acute tubular necrosis, what causes ATN?
Damage to the.
Yeah, the answers are on the slide. I haven't updated the slide yet. There it is. The answers are in front of the prompt slide. So lack of O2 to kidney tissues is the primary reason. You get ATN. And then other poisons again would cause this to happen.
Mm-hmm.
So this is how it should have come. It should have come this one and then this one. I got them backwards. I'll have to fix it. Okay. Acute tubular necrosis. What are the risks of acute tubular necrosis? And then what are the signs and symptoms? So the box on the left are the risks, and the box on the right are the signs and symptoms.
Okay.
I'm trying to get better because I know last unit we went through, you specifically asked for this kind of setup for this stuff.
Yeah.
That's why I'm starting to push really hard to add these bullet style risks and so that you get what you're asking for.
Yeah. I like it. Okay, so.
And if you have to look at the notes, let's go ahead and look at them. It's page 7.
Okay, so low blood pressure.
Hypertension, right?
Yep.
What's the key thing for low blood pressure? How long does it have to last?
30 minutes.
Yeah, 30 minutes, but it can, between 20 and 30 minutes, and that could cause ATN. Okay, the next one?
Septic shock.
Yep, septic shock. The next one?
dye.
The contrast dye used for X-rays and for internal studies. The next one.
Medications.
Medications that are toxic, and there are 3 types. Amygdalosides, there's 2 types. Amygdaloside antibiotics or amphotericin.
Okay. Injury or trauma that damages the muscles.
And the key phrase there, what's that called? What are those structures called that are released by the muscle?
Myoglobin?
Yeah, myoglobin structures or cells are released from the muscles and they travel to the kidney and they're too large and the kidney can't handle them.
Okay.
So that's like a femur fracture, maybe a large humeral fracture in a larger person, or like multiple rib fractures. If they broke 3 or 4 ribs, you might see those things getting released and then you'd see some kidney damage.
Okay.
Okay, the next one.
Blood transfusion reaction.
Can you tell me what's going on with that? What's going on with that?
It's rejecting the blood.
So what do we
call
not the same when it's rejected? What do we call that?
I can't remember what it's called, but it causes.
The term in the hospital is called mismatched blood.
Oh, okay.
We mismatch the blood, and then what happens?
It like clumps up.
Yeah, it clots because the body starts to attack it as a foreign tissue, and so clotting factors attach to those blood cells. They clot, and now you got a clot moving through your blood.
Yep.
And that can also happen how else? So that we can have mismatched blood, and we can also have RH mismatched blood as well.
Okay.
There's the base sequence A, B, B, O, right? Those can be mismatched. And there's the RH factors can also be mismatched. So we can have the type correct and the RH wrong, or we can have the RH right and the type incorrect. And in either situation is going to cause the blood to clump up.
Okay.
Okay, last one.
The recent major surgery.
Yeah, someone who's had a hip replacement, they basically got their bone broken. You know what I mean?
Uh-huh.
Really what's happened, they busted their bone. It's like breaking the femur. They busted their bone. Now they're immobile, and it's given those fat myoglobin and calcium products that have busted loose a chance to float free, as well as potential arteriosclerosis that's busted free because of the surgery. So there's plaque, calcium, and myoglobin structures that can all be busted loose during a surgery.
Okay.
So what are the signs and symptoms?
So change in level of consciousness.
Yep. Central nervous system change in LCs. What's the next one?
Oligurious or anuria, which is little urine or none at all.
You're already reading my mind. Perfect.
Full body edema.
Full body edema, which full body edema is characterized by what organ system failing in only that organ system? We're talking about it. If the kidneys fail, we're going to see full body edema. If the heart fails, we're not going to see full body edema. We're going to see backflow edema.
Yeah. So
kidney, full body edema is definitely a kidney structure issue.
Okay.
Okay. What's the next one?
Cardiac problems.
And this is specifically to what?
The potassium.
Yeah, potassium imbalances. The kidneys can't control that imbalance. They can't filter it back, and so then it causes ATN. Okay, then finally?
Fixed specific gravity.
What does fixed specific gravity mean?
So that would be, would it be too low?
Not too low. It means, okay, so remember in class we talked about you take their specific gravity at 9 o'clock in the morning, and it's 1.015. You take it at noon, it's 1.05.
Oh, yeah.
You take it at 4 o'clock, it's 1.015. What is that?
It's kidney failure.
Yeah, that's fixed specific gravity. It's not moving anymore. So you're not getting any filtration at all. Basically, the last time the kidney worked, that was the specific gravity it was set at. And now it's set at that point. It can't move at all.
Uh-huh. Okay. I remember that.
So the term for that is fixed specific gravity.
Okay.
Okay, and there are your answers.
Okay.
Number 8, I haven't done anything. Oh, no, okay. Number 8, it's renal failure. Okay. And it must be signs and symptoms. Yep, signs and symptoms of kidney failure.
Okay.
So they're very similar to ATN. So what are some of the ones for ATN?
Of signs and symptoms?
Yeah.
Well, they had the oliguria and the anuria.
Yep. Oliguria and anuria. And anuria. Yep. What's the next one?
The full body edema.
Well, it's not edema. This is anemia.
Okay, so.
Sorry, I'm sorry. I'm looking at the notes in the book and on my slides. And edema, full body edema is definitely one of the signs. Yep. Keep going.
Are you saying are we doing renal failure now?
Acute renal failure, acute renal injury signs and symptoms. So symptoms of acute renal failure depend on the underlying cause. But the sign that they're, yeah.
Okay. So oliguria and the anuria.
Yep.
And this one's anemia.
Which is what? Low oxygen carrying capacity of the blood.
Okay. It's spelled wrong on your slides, but that's okay.
Is it wrong on the slides? What's anemia? It's anemia.
No,
anemia, nausea and vomiting, abdominal pain, edema, periorbital edema, pale skin, history of taking drugs, history of trauma, history of recent infection, and acute tubular necrosis, or ATN.
So for 2, it's AN.
Yeah. Oh, Armenia. That's a country. That's not a process. It's a country. I'll have to fix that. I'm sorry.
You're fine.
Remember, I was doing this at 2 a.m.
I know.
And yes, it's okay to tease me. Thank you.
Okay.
That's what they are.
Okay.
Page 9. Treatment for acute and chronic renal failure. What do we do for this?
So, hospitalization, fluids.
Okay, look at the bottom of page 9. These are not ones that we've seen so far. These are new ones.
Yeah. Okay, so hospitalization.
They're in the hospital.
Administration of IV fluids in large volumes to replace depleted blood volume.
Correct.
Diuretic therapy or medications.
To
increase urine output.
So if we're giving them, if an antidiuretic holds on to sodium, what is a diuretic treatment going to do?
Gonna release?
It's going to ask the body to release that sodium, which is going to do what?
Increase the urine output. That makes sense. Okay.
Yep, it's going to release fluid with the sodium, and it's going to cause increased urine output, which is good. It's getting the kidneys to start to work again. If they're stopped and it's acute, they're going to give you a diuretic drug to get you to pee more, which is going to cause the patient to start up again. But what do you also have to do if you're doing that?
You're going to monitor?
You're going to monitor. I'm saying for the patient, they're going to be drinking a lot of water, and they're going to also be receiving IV fluids to keep their fluid level in front of that fluid loss.
Yeah.
Okay, cool. I'm trying to bridge that gap of thinking that they always push us to do. That if diuretic medications, you need to be giving them more fluids to compensate for the increased demand of fluid in the urine.
Yeah.
Okay, let's keep going. What's the next one? Close monitoring.
What did you say?
I said close monitoring.
Yeah, close monitoring. And then medications.
Yep. And what specific kinds of medications?
To control blood pressure.
Yeah, because remember how we talked about, so what kind of blood pressure medications do we have? Alpha blockers, ACE inhibitors, beta blockers, calcium channel blockers, and then we had our diuretics.
Okay.
Remember from our previous cardiac chapter, we had the ABCD hypertension treatment. So we've learned that the drugs we give people don't necessarily always act upon the heart itself to lower or raise blood pressure. It's a medication that can act on the kidneys to get it to happen.
Yeah.
By fluid volume changes.
Yep.
So if we affect that through medication, that can put us into kidney failure. And then specific diet requirements, low protein, and then obviously, low foods that are going to be digested into the urea and cause the kidneys to get poisoned. And then last but certainly not least, everybody's favorite way to treat kidney failure.
Dialysis.
Yep, everybody's favorite way to treat kidney failure, dialysis. Okay, 10. Okay, what are the 2 leading causes of kidney failure?
They are wait. Which page are you on?
I am on page 10, near the bottom.
Oh.
The 2 leading causes of kidney failure are what?
Well, does it have to do with the diabetes and hypertension?
Yep, that is correct. The 2 leading causes are diabetes and hypertension. That's the easiest slide you got. Because guess what? Moving on. Okay, what are our lab values from page 11?
Okay. So we have bun, which is less than 20. Specific gravity, which is 10, 10, 10 equals 30.
Yep.
Sodium, which is 135 to 145.
Correct.
Potassium, which is 3.5 to 5. Calcium, which is 8.5 to 10.5. And magnesium, which is 1.5 to 3.0.
Excellent. Good job. Page 12, it says complete exercises. 13 is complete exercises and 14 is complete exercises. So those ones, I just added the filler cards. What it's basically saying to you is do those on your own.
Yeah.
So what I would say is, and I'm doing the same thing, try to do those on your own for Saturday study group. And then when we meet with Adriana and you and I, we'll go over them together.
Okay.
And then we'll go through our answers together and talk about why certain things are what they are. Then that gives you a chance to fly on your own.
Okay.
On those pages. So guess what we just did today? So last night we did what?
A review of all of it, basically.
We went through every single page, and what did we do today?
A review of all of it.
We did a more detailed review of more stuff. So as we keep moving through the week, what am I going to keep doing?
More detailed.
I'm going to keep adding more details, but I'm going to do it by page so that by the end of the week, what have we done?
Everything.
We've done everything 6 times. We've seen every page 6 times as opposed to the first 4 pages a lot and the last 5 pages a little.
Yeah.
Okay, we good? Do you have any questions?
Nope, we're good.
Guess what? I'm done if you're done.
I'm done.
Okay. So again, I always ask this at the very end, is this productive for you? Is this a good use of your time?
Yes.
Okay, guess what? We studied for yesterday, and guess what we did today? We did exactly what Thomas asked us to do. We studied today.
Yep.
So if nothing else, you can be confident, and I feel more confident that when quizzes and tests come, I paid the price that she's asked us to pay, as opposed to going into those going, I really didn't do everything I could do.
Yep.
I don't like that feeling. If I'm going to bolo a test or quiz, I at least want to do it with the sense that I did everything that I could do as a student. And then when I bolo, then I can go to the teacher more humbly, but also more confidently saying, hey, here's exactly what I did.
Mm-hmm.
Opposed to, yeah, I blew it off and I didn't go to study group and I kind of looked at the notes. You and I can look her in the face and say, we really looked this stuff over.
Yeah.
Okay, so Sunday, I want to throw this out there. By Sunday, we should be through these notes pretty good, and we should be able to start to more aggressively look at section 8. Are you comfortable with that?
Yeah.
Okay, so let's get through this because that still gives us Sunday and Monday and Tuesday morning before class to still get ready for this quiz, but that gives us Sunday, Monday, and Tuesday to potentially look over Unit 8 and have 3 good days of review on our own to head into class on Tuesday very, very strong.
Yeah, I agree.
I think you and I think your learning style and my learning style is like that. The more chances we see something over a longer period, the stronger our knowledge of it is.
Yep.
Cool. Okay.
Okay, cool.
I'm signing off if you're cool.
Yep, so I got my schedule, like I said yesterday.
Yeah, just send it to me or put it in your calendar and invite me to it so I can see it, and then I'll know what's going on.
Okay, sounds good.
But like I said, as far as I'm concerned, around your schedule and my schedule, we're just going to adjust fire. If you work 7 to 7 at night, 7 in the morning, we'll have it at 8:30 in the morning. If you work 7 in the morning to 7 in the evening, then it makes more sense to have it at 9 or 9:30.
Yeah.
And I think those sweet spots meet our schedules both pretty well. It's not digging into your sleep time. You know what I mean?
Yeah.
Not digging into the middle of my sleep time, which I think we want to avoid.
Yeah, I agree.
So, and as for the other people in the study group, I don't know what they're going to do. And I kind of, I care. I'm hoping that they'll come on board a little bit more consistently.
Yeah.
So, okay, cool.
Okay.
You have a very pleasant day. If you need to get a hold of me for anything, just let me know.
Okay, I will.
Okay, awesome.
Okay. See you.
Bye.